Good morning, everybody. Welcome you to today's lecture. Today we'll be conducting a session on neonatal jaundice and the homeopathic therapeutics associated with it. We'll just wait for a few minutes while people are joining in, and then we shall begin today's discussion. The reason for choosing this topic to present for you today is, of course, one is that it is part of the syllabus, both third BHMS as well as, neonatology is also a section for those of you who are pursuing your MD in pediatrics. So this is why I've selected this topic. And of course, the main reason for selecting this topic is your actual clinical practice, because this is one of the conditions where we as homeopaths have good scope. You may not get to see too many cases in this young age group, but yes, when you do get the opportunity, you have very good scope. Remember that. And so you should be quite confident and have the knowledge of how to treat it. Small introduction about myself. I'm Dr. Kanika Sabharwal. I'm a practicing homeopath in the city of Mumbai for last 8 years. And I'm also an assistant professor in the Department of Obstetrics and Gynecology at CMP Homeopathic Medical College in Mumbai. And I've been teaching here for the last 5 years. I completed my MD in pediatrics, so this has always been one of my topics of interest, has always been pediatric and gynacs. So let us begin with a small introduction to this particular topic. As you all are well aware, when you talk about, yes,
Okay,
would
start,
somebody
ma'am.
like to ask?
Start, ma'am. Start.
Sorry,
Continue, ma'am.
I can continue.
Yes.
Oh, thank you. All right. So if you do have any questions, anybody, you can, if you'd like me to stop and repeat something, you can ask me, or else you can post it in the chat box, or you can ask at the end of the session. So let's begin with a small introduction. As you all are well aware, this word jaundice is used to refer to a yellow discoloration of both skin as well as mucous membranes. This takes place when there is elevated levels of serum bilirubin, and these elevated levels of bilirubin go and accumulate. Accumulate means they go and collect or they deposit in either the tissue or the plasma. We diagnose the condition, we say that the patient has jaundice or icterus when the serum bilirubin, now here we are talking about total bilirubin, which is the sum of direct as well as indirect bilirubin. So total bilirubin goes above 5 mg per dl. If the patient has a total bilirubin value that is actually more than 15 mg per dl, please understand that this is a very severe condition, and this comes with more severe consequences and long-term complications. So be quite alert if the patient's bilirubin is constantly spiking on day 2, day 3 also. As I for taking up this topic is definitely because it's a part of our exam syllabus, but more importantly, the other reasons for taking up this topic, one is that it is very common. As you see here, it is seen in 60% of neonates. Now 60% is quite a large figure. You're talking about more than half the newborns. And another reason for understanding and treating this topic is sometimes, depending on the underlying cause of the jaundice, more severe complications are possible which are not curable. Mind you, they may be treatable, but they are not curable. And some of these are deafness and a condition known as cerebral palsy, which occurs due to a particular complication known as kernicterus. I'll be talking to you about kernicterus also shortly. As you all are well aware, congenital deafness or an infant born with cerebral palsy leads to very poor life quality. It is very difficult for the parents and caregivers also to manage such children and their needs. So this is why we must be very alert and we must treat the jaundice and its underlying cause immediately. Before we proceed to our actual topic, it's always nice to get a quick revision of our basics. So let us run through a little bit of the physiology of bilirubin and biliverdin, how it is made and why it leads to this particular condition. So starting off, as you all know, the origin of this molecule comes from the breakdown or the hemolysis of the RBCs. So erythrocytes, either when they have completed their lifespan or due to any underlying cause of hemolysis, they break down to giving you the heme and the biliverdin molecule. This process is taken place or is controlled by an enzyme known as heme oxygenase. Biliverdin is further reduced to the bilirubin molecule, and this process is controlled by an enzyme known as biliverdin reductase. This entire process takes place under the control of the RES, or what is known as the reticuloendothelial system. Once bilirubin is formed, it has two modes of getting processed. And that's what gives rise to what we know as the direct and indirect bilirubin, also known as the conjugated and unconjugated. So what are these two processes which bilirubin can undergo? First is it directly goes into the serum where it is, ideally it is called as a free bilirubin, but that's a little bit of a misleading term because this free bilirubin is loosely attached or loosely bound to an albumin molecule. This bilirubin, that is known as the unconjugated bilirubin, can circulate freely in the serum. However, it has two important consequences which can prove to be problematic to us. One is it can cross the blood-brain barrier and affect the brain, various areas of the brain, and that is known as kernicterus. Also, it has the ability to cross the placenta, and by crossing the placenta, it may go towards the maternal organism and may affect the mother also. Fortunately, we don't see this very commonly. The other pathway that bilirubin can take up is where it undergoes a process of conjugation. Conjugation of bilirubin takes place in the liver under the influence of an enzyme known as UDPGT. What does this stand for? This stands for uridyl diphosphate glutamyl transferase. I know it's a little long name, but this is not something new for you. All of you have been good students of physio, so you're quite well aware of these things. Under the influence of this enzyme, the bilirubin gets conjugated, whereby it is joined to a molecule known as gluconic acid. And conjugated bilirubin is the one which is excreted in bile. It enters the enterohepatic circulation, and after it gets broken down, it forms the compounds known as stercobilinogen, which is present in the stool sample of a patient with jaundice, and urobilinogen, which is present in the urine. So I hope this has given you a quick overview and a revision of how exactly bilirubin is formed and how it circulates in the bloodstream. Remember, you have done this experiment in physio as well as patho lab where we test the urine routine sample, also gives us the report, and we test it for bile salts and bile pigments. So this is what we are referring to when we test for presence of bile pigments and bile salts, and we get a clue of whether the patient is suffering from jaundice or not. So at this time, I just want to clarify that we have two terminologies that are used: jaundice as well as icterus. Now, icterus simply refers to the yellowish discoloration, which is the examination finding, and jaundice is the name of the condition. There are various causes of jaundice, one of which is hepatitis. So please don't get confused. Sometimes people use these terms in an overlapping manner, but so I just wanted to make it clear for you. Hopefully, you all have understood this, so we can go ahead with our proper part of today. As we said in our previous slide, we have something known as direct versus indirect bilirubin, which are also known as conjugated and unconjugated respectively. So let us understand the difference between both of these. Firstly, conjugated bilirubin, as you saw in the previous slide, is the one which is present in the bile, whereas the unconjugated one is present in plasma. Conjugated is so called because it is conjugated and bound to glucuronic acid, whereas unconjugated is loosely attached to albumin. And because of the process of conjugation, this bilirubin is a small molecular weight molecule and it can be filtered out. Therefore, it is present in urine. Unconjugated bilirubin remains as a high molecular weight substance and thus cannot be filtered out by the kidney, therefore is absent in urine. Why am I talking to you about all this? Because this gives you a clinical clue when you have reports in front of you. Remember that when you're talking about neonatology, much of your prescription and much of your understanding of the disease is going to be on observations. The newborn cannot talk much and the parents cannot describe many symptoms of the newborn child. So what you're going to be dealing with is predominantly you're going to be dealing with your observation findings. And this is why it is important to pick up on these clinical tips. However, conjugated bilirubin is not so good because it is better for us in terms of severe consequences because it cannot cross the blood-brain barrier. Whereas the unconjugated one can cross the blood-brain barrier and lead to what is known as kernicterus. Purposely, you can see that the slide is in red to denote that this is something a little dangerous and we need to be a little careful about it. The reason for calling conjugated bilirubin as direct is because it gives us a direct positive reaction when we undergo the Vandenberg test or the Vandenberg reaction. This also is an experiment which all of you have seen, so I'm not going to explain it in much detail. Whereas the unconjugated bilirubin is known as indirect bilirubin because it doesn't give us a direct reaction for Vandenberg. We have to add another step and a middle reagent, and only then we get a positive reaction for it. Therefore, the name indirect. Because conjugated bilirubin cannot cross the blood-brain barrier or the transplacental barrier, it is relatively non-toxic, whereas unconjugated bilirubin is toxic. I hope this has made it a little clear. Now we come to causes of neonatal jaundice. Here we have two important variants. One is the physiological one and one is the pathological. As you all are very well familiar with these terms, physiological is that which has no underlying disease or pathological process, whereas pathological refers to the fact that there will be an underlying pathological or structural changes taking place. How will you differentiate these two clinically? Remember, physiological jaundice, the most important criteria is a child is never born with it. So if you are seeing the child on day 1, immediately few hours after birth, and the child is icteric and has yellow discoloration of the conjunctiva, the nail beds, you are looking at a case of pathological jaundice. The way physiological jaundice progresses, it usually starts after 24 hours, and that is on day 2 or day 3 it may start sometimes. It progresses for 1 week and by day 10 it is usually reversed. Now here the word is disappeared to tell you that this condition can get well on its own. It doesn't necessarily always require treatment. On the other side, we have pathological jaundice, which typically comes up on day 1, that is within the first 24 hours. So here, if you see that baby on day 1 of birth and the child is already icteric, think that there is an underlying pathology that you need to find out the cause of. Pathological jaundice also lasts sometimes longer. In a full-term infant, usually it lasts for more than a week or more than 10 days. And in a preterm infant, it lasts for more than 14 days or 2 weeks. A preterm infant is an infant born before 37 completed weeks of gestation. In physiological jaundice, we usually see an elevation of the unconjugated bilirubin. Whereas in pathological jaundice, we usually see the conjugated type which goes up. Again, this is another clue because when you will see the LFT report in front of you, when you get the blood test report in front of you, first thing you will see is total bilirubin is elevated. So you know, yes, the child has a jaundice. To try and understand which type of jaundice it is so that you know the prognosis of the disease better, try to see whether it is the unconjugated or the conjugated variety that is higher in the report. Usually, physiological jaundice reaches the peak of a maximum of 10 to 12 mg per dl, whereas in pathological jaundice, it can reach much higher levels. On an average, we see that the bilirubin levels begins to increase or jump up by 5 mg per dl every day in case of pathological jaundice. When you treat these sort of patients, needless to say that if it is a pathological jaundice which has been diagnosed on day 1 of birth, the child is going to be admitted in the hospital. And for that, even if you are called to treat as a homeopathic physician and there is some modern medicine treatment going on in the hospital, please ask for an update on the bilirubin value every 24 hours so that you can keep a check that with treatment, this jump of 5 mg per dl is not taking place. So what are some underlying processes? Why do we say that so many babies are prone to this particular illness? So let us understand the various processes that could lead to physiological jaundice first and subsequently pathological. Remember to go in a very stepwise manner so it's easy for you to remember and you don't have to, sort of sit and memorize facts. Always correlate with your physiology. The first thing is there could be increased RBC volume. This could be because of excessive production or it could be because of excessive destruction in a case of hemolysis or excessive hemolytic processes. The second thing is the RBCs could have a shortened lifespan. As you know, neonates or children have the RBC lifespan of 90 days as compared to 120 days in adults. So that could be one reason where there's a shorter lifespan, so they undergo faster hemolysis and degeneration, contributing to elevated levels of bilirubin. The third process is because there are still immature processes in this newborn. All their structures and physiological processes have not developed 100%. So there is immature hepatic uptake, which is required for the process of conjugation. So conjugation is affected, and if conjugation is less, the excretion into the bile and into the enterohepatic circulation is also less. And once you understand this step, you understand why when we spoke about physiological jaundice in the previous slide, we said it is more of the unconjugated variety that increases because the process of conjugation itself is not fully developed. I hope this is clear to everybody. We'll move ahead with pathological jaundice. Similarly, we go in the same flowchart broadly. First cause could be excessive production of bilirubin. Second, reduced hepatic uptake. Third, conjugation being a problem. Fourth, excretion being a problem. And fifth, transport of bile being affected, what is known as impaired bile flow. So as you see here, it is exactly each step that we spoke about in the first slide of today where we revised how bilirubin is produced and how it circulates in the body. Here we are talking about a problem at every single step or level of that process. And a problem at any of these 5 steps could lead to pathological jaundice. Just to give you some examples to make this a little clearer, I have put clinical conditions correlated with the underlying pathology. So first mechanism we spoke about was excessive production of bilirubin, in which case we usually see more of the unconjugated variety. Excessive production could be because of a fault in erythropoiesis. Erythropoiesis refers to the process of formation of our RBCs. Second reason could be any hemolytic anemias. As you know, hemolysis is the process of destruction of RBCs. And the third cause is blood extravasation. Extravasation means oozing out of the blood vessel itself, but not an overt bleeding on the skin. Second process is the hepatic uptake, where there is a problem in the liver. This is seen in a congenital condition known as Gilbert syndrome, or sometimes it may be drug induced. When we say drug induced, remember that most of medicines consumed, particularly when we talk about allopathic drugs, they are metabolized and digested by your liver. So under the influence of certain of these medicines, the hepatic uptake of bilirubin could be affected. The third process is impaired conjugation. Now, impaired conjugation has various causes. The first, which could be something known as breast milk jaundice. Now, breast milk jaundice, as the name suggests, is the type of jaundice seen in an infant who is exclusively on the mother's milk. Why does this take place? This takes place because the baby's liver is unable to digest a particular molecule present in breast milk. It usually, this is not a very permanent condition. It doesn't mean that the child is going to be, lactose intolerant for life. It is a temporary phase where that digestion is not 100%. Other reasons for impaired bilirubin conjugation include genetic deficiency of an enzyme known as glucuronidase transferase, certain congenital conditions known as Crigner-Najjar syndrome, as well as Gilbert syndrome. These are seen, they are congenital conditions or inherited conditions that the child is born with, and they occur due to deficiency of the enzymes we spoke about at the start of the session that are required for metabolism of bilirubin. There may be an obstructive variety. You all know that we have something known as an obstructive jaundice, which may be due to extrahepatic causes or intrahepatic, that is a biliary stricture. Stricture means narrowing, and therefore the outflow or the production of bile flow is impaired. In extrahepatic, we have something known as extrahepatic biliary atresia, which is again something the child is born with. As the name suggests, atresia refers to underdeveloped. So the entire biliary tree and blood vessels are underdeveloped, and this child is prone to recurrent episodes of obstructive jaundice. To give you examples of some pathological jaundice, which is more of the conjugated bilirubin gets elevated, we have neonatal hepatitis. Now, hepatitis, as the name suggests, refers to inflammation and underlying infection of the liver, which may be due to viruses and other causative organisms. What we see commonly in clinical practice is a newborn born to a mother with torch infection. Torch infection stands for a group of viral infections which affect women during pregnancy, and depending on which immunoglobulin is higher, it has the ability to cross the placenta and cause a transplacental affection of the baby. We'll do a quick revision for torch in case somebody is not aware. So TO stands for the toxoplasmosis virus, R for rubella, C for cytomegalovirus, and H for hepatitis as well as herpes. This is a group of viral infections which we prefer if our pregnant patients don't get affected from it, because as I said before, it can transmit to the baby or it can lead to recurrent abortions also in the mother. Another condition where neonatal jaundice is common is a condition known as trisomy 21, also known as Down syndrome. Down syndrome, unfortunately, is not as rare as we would like. It is seen in 1:700 newborns. And as you know, 700 newborns are born almost every minute in the country that we live in. So trisomy 21 is also seen, is also associated with predominantly a conjugated hyperbilirubinemia. Lastly, we have biliary atresia, which depending on the affection or the extent of involvement can lead to either unconjugated or conjugated levels of bilirubin. Now that we have understood the various causes, let us come to a clinical evaluation. Although in today's day and age, we don't rely much on this, we give more importance to our investigations. This is a guidance tool which you can use to gauge roughly the level of bilirubin. So it is known as Kramer's index. As you see, we have some numbers in the diagram. Now, depending on these numbers, depending on which area of the child is icteric or which has the yellowish discoloration, we get a rough idea as to what the serum bilirubin level will be. So let us understand Kramer's index. If the extent of the icterus is limited just to the forehead, to the eyes, what is known as dermal zone 1, you can understand that this is a mild case of jaundice where bilirubin level is approximately 5 mg per dl. If the extent or the icterus is spread lower below the neck involved further, if the extent of bilirubin is still lower, involving the lower abdomen, pelvic area till the thighs, we understand that the patient's bilirubin level is slightly more, that is 12 mg per dl. Further down, if the entire head to toe of the child is icteric and has a pale yellow discoloration, but hands and feet are spared, you understand that roughly the bilirubin level is around 15 mg per dl. If even the palms and the soles are involved, if no part of the body is spared, understand that the child's bilirubin level is more than 15 and there are chances that this child could have kernicterus, particularly if it is an unconjugated bilirubin that is high. As I said before, we rely more on our investigations for this particular condition rather than examination. So what investigations would you like to look at? Firstly, we like to see the CBC to get an estimation of the RBC count and also ask for a reticulocyte count. Reticulocytes, I'm sure you all know, they refer to the immature RBCs. So in a patient who is having severe hemolysis or destruction of RBCs excessively, the body sends a negative feedback, the body gets, via the negative feedback mechanism, the body gets a signal saying, I need more RBCs. So these immature RBCs, known as reticulocytes, are released into the bloodstream even before they complete full development. So this gives you a clue of an underlying hemolytic process. The most important investigation, of course, for jaundice remains the LFT, which is the liver function test. You will look at the total bilirubin, and then to try and understand what the underlying cause may be, you will look at the direct as well as indirect components. In neonatal jaundice, there's a particular test known as the Coombs test, which we do to understand whether it is a hemolytic or an autoimmune process. So we have two variants, the direct as well as indirect Coombs test. And in the infant, what you require is the direct Coombs test. Further, we would like to get a blood group estimation of both mother and infant. And the reason for this is we want to rule out any RH incompatibility. RH incompatibility leads to excessive hemolysis and a condition known as erythroblastosis fetalis. So that could be one cause of jaundice. Therefore, it's important to get a blood group estimation. As you all are well aware, blood group of the mother forms a part of her antenatal investigations, and that is done in the first ANC checkup that she undergoes. Further, we may require what is known as hemoglobin electrophoresis. As you all are aware, electrophoresis is the process by which we can see the individual bands of hemoglobin and the type of hemoglobin. This is important for certain conditions such as thalassemia and to understand whether the underlying cause lies in a hemoglobin pathology. Also, don't forget to do thyroid function tests of the infant, especially if the mother is a known case of hypothyroidism. Because hypothyroidism in the mother can lead to what we call as cretinism in the newborn baby, which means that the newborn baby is also affected with hypothyroidism. And that is a very common and important cause of prolonged neonatal jaundice. So if the jaundice is persisting, it's been the first week, it's been 10 days, the mother calls you up saying, Doctor, I was discharged from hospital, they did everything in the hospital, but still my child's jaundice is not clearing up. Please ask for a thyroid function test and look at the TSH values. Lastly, you can consider doing a G6PD. G6PD is an enzyme which some people are found to have a deficiency of, and that could lead to one of the causes of prolonged jaundice. G6PD deficiency is seen in certain communities of India. So this is something that you must keep at the back of your mind, and don't forget to get a G6PD level done if other causes have also been ruled out. All right. Now that we have understood this process, its causes, its clinical manifestations, and its investigations, let us understand a little bit about the treatment carried out in modern medicine. And then we can move to homeopathic management. There are basically three modules of treatment which are followed in modern medicine. Of course, technically, it's not important for us to know the details of it. So we'll just explain to you the principle behind it. The first is something known as phototherapy. All of you who have seen patients who have attended OPDs or hospital wards, you would have heard कि डॉक्टर मेरे बच्चे को लाइट के नीचे रखा था, जन्म होते ही उसको पीलिया हुआ था तो लाइट दिया था. So this is the way the lay people or the mother tells us, and what we understand by that is it is phototherapy that she is referring to. Pília, as you know, is a layman term for jaundice. What does this phototherapy do? By exposure to this light, it converts bilirubin to a water-soluble form that can easily be excreted out of the system. The second treatment modality that is used, of course, phototherapy is used most commonly, and that's why we should all be aware about it. The other method used is something known as phenobarbital therapy. This promotes bilirubin conjugation and thus excretion by formation of uro and stercobilinogen. Why is this important? This is important for two reasons. One, because we discussed earlier, infants have immature hepatic uptake and conjugation. So by giving phenobarbital, you are promoting the conjugation process. And second important thing is when you convert unconjugated to conjugated bilirubin, you are reducing the chance of kernicterus and of unconjugated bilirubin crossing the blood-brain barrier. The third method, which is used in more severe cases of neonatal jaundice, is something known as exchange transfusion. As you know, this word transfusion, blood transfusion, you all have heard of. And the word exchange means to replace something. So what are we doing? We are removing bilirubin and antibodies from the circulation and replacing it with healthy blood that does not carry those antibodies. This can be used in cases of Rh incompatibility and other autoimmune causes. This has an added advantage where it will also correct the anemia because you are supplying healthy blood which has the adequate level of hemoglobin. So these three are the mainstays of treatment that are followed in modern medicine. But as we said, this is not something that we are going to execute, but we should just be aware. Now let us talk a little bit about kernicterus. From your exam perspective, kernicterus is usually asked as a 2-mark short note, so we'll just understand a little bit about it. It is a pathological condition which is characterized by a yellow staining or by icterus of the brain because of elevated unconjugated bilirubin. And this leads to a neuronal or a CNS injury. Which sides of the brain are usually affected? It is the hippocampus, stem along with the basal ganglia and many of the cranial nerve nuclei. If a patient has kernicterus, remember that the total bilirubin level is usually between 15 to 20 or can cross 20 mg per dl. If not treated immediately, it can lead to more long-term consequences which would leave the child affected for long. And of course, altered life quality. But having said that, let us move to our role as a homeopath. Always, when we talk about different clinical conditions, we must first understand the disease, right? We all know in Organon aphorism number 3, it's right at the start, where Dr. Hahnemann says knowledge of disease. So when you have knowledge of disease, you will understand the scope. Our scope is variable depending on the underlying cause and the extent of pathology. What do I mean by this? I mean that if you have a case of jaundice, either which is physiological or which is pathological due to certain causes like we discussed earlier, which could be excessive hemolysis or immature uptake, you have good scope. If it is a case of Crigler-Najjar syndrome, Down syndrome, your scope becomes a little restricted. And if it is biliary atresia or a congenital structural pathology, child is going to require treatment for much longer. And your approach has to be different. You have to take more of a pathological approach. So you have to decide your scope only after you have diagnosed the underlying cause. It is not enough to say the child has jaundice. Yes, I can treat very well as a homeopath. No, be practical, understand the picture, and then go about treating. So we come to a question whether we really need to treat physiological jaundice, because as we have now understood, it usually disappears by the first 7 to 10 days. So should you treat it? My answer to you would be, if you have been approached by the parents with concern, if they see some symptoms, in the sense they say the child is not feeding properly, the child is dull, or the child is disturbed, yes, you can treat it. What will your treatment do in a condition which is anyway going to be self-limiting? Your treatment will quicken the process, make the child get well faster, and be at ease immediately by day 2 or day 3. So if the parents have understood, they have been explained by their pediatrician and obstetrician that this is normal, you can take the child home, the child is eating well, sleeping well, parents have no problem, they will not even approach you. So those cases, of course, don't require treatment. How should we approach these cases? Needless to say, of course, you will be approaching and treating with acute totality, and your focus will be on objective symptoms. No subjective symptoms. Child cannot explain what he or she is feeling or what is going on. It's completely on what you observe, little bit of what the parents tell you. Give some importance to your clinical findings. If on examination you see something peculiar, perspiration on a particular part of the body, or child assuming a particular position, always lying on the right side maybe, or pathological findings that you see, as well as what is mentioned in the report. So give importance to all these things, form your acute totality, and start with a remedy in low potency, which you may give in repetition. But most importantly, please be available to your patients. Monitor the child frequently, because the child is so young. You need to be alert and ask for a daily report. If child is admitted, you ask for bilirubin every day, which anyway they would be drawing blood and doing in the hospital. If the child is at home, tell the parents to monitor the yellowish discoloration. And if you can, of course, not now in coronavirus times, but otherwise, if you can make a house visit, go and examine the child yourself. So having understood how we will approach it, let us now come to our therapeutics. Which remedies will we find useful in this condition? You will see for all the remedies, I have described it to you just under these subheadings, all which are more objective. So we'll be discussing any ailments from, if there is characteristic in that remedy, we'll be talking about the tongue, which you can observe easily, the local GIT symptoms, the stool urine pattern, and the skin. These are the broad headings we're going to talk about for the next few remedies. First remedy is aconite. Aconite, you all are well aware, is one of the best remedies for ailments from fright. So if there has been an episode of fright, either in the child or of course in the mother, some news or she was very, very afraid of labor, you get a strong history of fright, you can think of this remedy. When you examine, the tongue has a white coating. Local symptoms are very important. The child has vomiting as well as diarrhea, and the vomitus consists of greenish material as well as bloody mucus. So the word hematemesis means blood in the vomitus. Similarly, we see the same greenish discharge in the stool, where the stool appears green, and in your textbook they describe it as chopped up herbs. There is a watery stool in children. As regards the urine output is scanty, and the urine passed is quite hot and painful. Now the child cannot say that my urine output is painful, so the child cries while passing urine, and that's how you understand that either the urine is very acrid or the child is experiencing pain. When you examine the skin of an aconite patient, as you know, it's a good remedy for flushing. So the skin is more red, which is not very easy to understand with the ecteric picture. But you may be able to notice a papular rash like measles. Certain general symptoms include a very restless child who is not able to sleep peacefully. Aconite forms the trio of restlessness along with arsenic and rust ox. So this restlessness is seen right at the start in a very young child also. Aconite has a very important symptom where everything tastes bitter to the person except water. Now, this is not so applicable in newborns because, typically they are not given anything apart from breast milk and water is not started so early. But you will understand this in the way that the child is vomiting. So you understand that the child is not even finding the breast milk or the formula milk very palatable or tasty. Next remedy we move on to is bryonia. Bryonia, very good remedy for respiratory as well as liver affections. So the tongue, when you examine, has a thick white coating. Lot of bilious vomiting in bryonia because of liver involvement, and this bilious vomiting is worse after eating. So after the mother has fed the child, she says that he or she brings up the milk as a vomitus, and it is a bilious fluid. When you examine, when you palpate per abdomen, there is soreness of the liver region, that is the right hypochondrium, and lot of tenderness of the abdominal walls. So when you palpate, the child will either start crying or screaming because of so much tenderness. Bryonia is a good remedy both for constipation as well as diarrhea, where the stool is brown or red mixed with blood, and it's a good remedy for early morning diarrhea, where the patient has to rush. Now, of course, children, it's all in the diaper, but you can ask this to the mother. She will tell you that, yes, doctor, moment I wake up, my child's diaper is full. So be very alert, know what type of questions to ask when you're treating neonates. As regards the urine is scanty, again, a hot, same as we saw in aconite, but here it is more brownish and a little frothy, like the alcoholic beverage known as beer, which has a little bit of frothy layer on the top. Now, these remedies have been proved abroad, so they have correlated to foods and drinks which are available over there. The skin, of course, being a case of jaundice, has a yellowish discoloration or sometimes pale. Now, pale skin and constipation, both these two symptoms tell you that bryonia can also be given for obstructive jaundice. So this is how we like to correlate clinical medicine as well as our theraps. A general concomitant, the child does not like to be carried or raised up. This is very characteristic because most children love to be carried. In fact, they fall asleep only when they are carried sometimes. And your other children's remedies like Cinna and Chamomilla, they love to be carried. So this is a characteristic of bryonia, which we don't see in many other remedies. The next remedy I would like to describe to you is something known as Cardis marianus. Cardis is one of the best remedies with a strong sphere of action on liver and biliary system. In fact, most modern medicines which are indicated for liver pathologies, they contain an active principle known as silimarine, which comes from the Cardis plant. So that tells you that even in modern medicine, they use the same plant substance. When you examine Cardis, the tongue has a thick fur-like coating which is all over. There is vomiting of green acidic fluid. Acidic fluid means that again it is a bilious discharge. Remember, the words sour or acidic or yellowish green should tell you that you're talking about a bilious discharge. On examination, the liver is palpable, it is enlarged, particularly there is tenderness of the left lobe. This used to be very characteristic because earlier an illness known as syphilis, which was very rampant in the olden days, always affected the left lobe. Now it's not so important because we don't see much of syphilis nowadays. In Cardis, we have a concomitant where liver affections are associated with respiratory or lung disease and they lead to hemoptysis. Hemoptysis means blood in the expectoration while coughing. As regards the stool, like bryonia, we have a diarrhea alternating with constipation, and the diarrheal stool may be bright yellow or clayey. Clayey stool is a pale, pasty stool which could represent, again, obstructive jaundice. Or they may be melena. Melena refers to blood in the stool. Particularly, our upper GI bleeding leads to melena, which is dark blood stain in the stool. The urine, like bryonia, is cloudy and foamy with a golden yellow color. Again, deep yellow color is very characteristic of jaundice. And the patient has a lot of itching on the skin, particularly at night. Remember, bilirubin goes and deposits on under your skin on the collagen and elastin tissues. Therefore, itching is a very common symptom seen in jaundice. Itching all over the skin. There may not be any rash, but it is due to elevated bilirubin. Next remedy, I'm sure you all are very familiar with. It's also asked very frequently in the exam and it's a very well-known liver remedy, chelidonium. When you examine, the tongue appears as though it is swollen or flabby. It is very thick and has a yellow coating. So this yellow discoloration you see starts right at the examination of the tongue. As regards the GI symptoms, it is a good remedy for both hepatic jaundice as well as post-hepatic or what we call obstructive jaundice. On examination, liver is palpable. Nausea and vomiting better by very hot water or hot drinks. You know this symptom of chelidonium, even in adults, they enjoy warm and hot food and drinks. Eating relieves the nausea and pain temporarily. So the mother will tell you, after I have fed my child, he is okay for some time, and thereafter there may be a vomiting. Chelidonium is indicated more for constipation, where the stools are like similar to natramur or any other muriaticum, where there is hard ball-like stool resembling sheep dung. Alternatively, there may be a clay-colored pasty diarrhea which floats in water. Remember, when there is stool floating in water, it could tell you that there is also some degree of malabsorption, especially fat malabsorption. Diarrhea alternating with constipation. Urine is profuse, not scanty like iconite and bryonia, and dark yellow color like beer with frothing. Again, telling you that there are bile pigments present in the urine output. Because of these bile pigments present, this urine stains the diaper dark yellow. Again, an examination findings, which the parents will be able to tell you or you will have to observe on your own. As regards the skin of chelidonium, it is yellow discolored with a cold and clammy feel when you touch it. Here you see in chelidonium, there is the icteric appearance all over the body. So dirty yellow color of eyes, face is yellow discolored, skin is itching and yellow and a sensation of dryness. A concomitant in chelidonium, which you may not be able to see at such a young age group, which is constant pain under the inferior angle of right scapula. So this is a referred pain, which from right hypochondrium goes backwards to the inferior angle of scapula. In the source book, in Clark's Materia Medica, we have the exact symptom of chelidonium for jaundice, which says bilious complications during gestation. Gestation is pregnancy. Next remedy is China. Remember, an easy way of remembering theraps for jaundice or any other liver affection is the alphabet C. A lot of remedies with C are very useful for treating liver conditions. You have China, you have Jaundice, you have chelidonium as we just spoke about, you have Neonatal. So many of these remedies beginning with C are very good for liver pathologies. China, as you know, is a good remedy for ailments from loss of vital fluids, which here you could interpret as a hemolytic anemia because loss of blood or red blood cells. When you examine, the tongue has a thick and dirty coating with a bitter taste in the mouth. Constant pain in the right hypochondrium, and when you palpate, both liver and spleen are palpable. This is a common finding for those of you who will be working and dealing with pediatric patients. Newborns sometimes have palpable liver and spleen because of excessive hemolysis. As you know, in China, milk doesn't suit the babies. It's a good remedy for lactose intolerant. You know, the mother may say, my child gets very colicky, either with breast milk or with formula, leading to flatulence, belching, and sometimes hiccups. China is a good remedy more for the loose stools, which contains undigested particles. Stool is frothy, yellow in color, and passes painless. More diarrhea seen at night and after a feed, and worse during hot weather or from milk. The urine has either a pinkish or a reddish sediment, and it's a good drug for hematuria also. The skin, of course, as you know, common symptom will have a yellowish discoloration. Next remedy which we move to is ipecac. Ipecac has a strong action on what used to be called the neogastric nerve and is now known as the vagus nerve. The hallmark symptom of ipecac is excessive nausea with clean tongue. This is where your examination becomes so important. Each remedy that we have studied today has a different presentation of the tongue. So mouth is constantly moist with excessive salivation, which also makes the patient thirstless. Constant nausea and vomiting, vomitus of the food, as well as bilious fluid, as well as mucus, as well as blood. So any type of vomitus. And stomach feels relaxed. Of course, this the child cannot tell you. Again, a characteristic symptom, vomiting of infants at the breast, which tells you that even in the proving, we found this symptom at such a young age group. Stool is mostly a diarrhea pattern. It may be yellow, green, or brown in color, which is frothy. Your textbook mentions frothy like molasses. What is molasses? It is a byproduct of sugarcane processing. Sometimes the stool may be bloody or slimy, containing mucus. Again, same thing you see at the urine. Also, you see in this particular remedy, it has bloody discharges, be it vomitus, be it stool, be it urine. Associated with cutting pains in the urethra and chest oppression. Chest oppression means difficulty in breathing. So again, the child will cry while passing urine. As regards the skin, there is itching associated with this excessive nausea. The child will scratch till he vomits. This is a very characteristic symptom also, not seen very often in clinical practice. Next remedy, some of you may not have heard of this remedy. It's known as Myrica cerifera. Like Cardis, it has a marked sphere of action on liver as well as entire mucous membrane of GI tract. The tongue is furred with a bad taste in the mouth because of the thick furry coating, and that leads to nausea. The saliva is very tenacious and thick. Tenacious means with increased viscosity. In Myrica, it has, apart from liver infections and jaundice, it also has cardiac symptoms as well as urticaria. So you have skin involvement, cardiac involvement, as well as liver involvement. This nausea is worse while eating and better by rapid walking. Again, rapid walking is not so useful for the child, but yes, if you have a mother who says, my child wants to be carried and wants me to walk up and down the room, maybe you can interpret it like that. Pain in the region of the liver, stool, which is, now here the stool is very characteristic. It is a diarrhea type stool, which is light colored or ash colored and destitute of bile. What is the meaning of this word destitute? It means deficient or absence of bile in the stool, indicating that it could be an obstructive pathology. Urine, on the other hand, is dark, frothy, and high colored. High colored again means high specific gravity. So you see each symptom I'm trying to correlate for you the underlying pathology. The skin, when you examine, has a bronze or yellow tinge and is associated with itching. This is a common symptom which we have already spoken about. Next remedy is natrum sulph. You may have studied natrum sulph in biochemic remedies. So you know it's a good remedy for liver affections as well as respiratory again. The tongue has a brownish coating. There is a lot of vomiting, which is sour and bilious. It is a good remedy for acidic dyspepsia. What is dyspepsia? In layman language, it is indigestion, where there is acidity and flatulence. It's a good remedy for hepatitis, which is inflammation of the liver, leading to icterus and bilious vomiting. When you examine, the liver region is sore to touch with sharp and stitching type of pains. Pains are so sensitive that the child doesn't like any tight clothing around the waist. The mother will tell you, my child likes to be uncovered, doctor. They throw off the clothes and any covering. Vomiting is worse when lying on the left side. Diarrhea, with a characteristic symptom that will really trouble the patient's parents, is great size of fecal mass. The mother will say, doctor, my child passes so much stool that sometimes it leaks out of the diaper. Now, this is a symptom which we get often in clinical practice, so you'll be able to assess it. Like bryonia, like aloe, natrum sulph has an early morning diarrhea, which is yellow in color and watery stool. Urine is loaded with bile. See how typical and how easily these symptoms are explained. Loaded with bile and has a brick dust type of sediment. The skin has yellow complexion, yellowness of the conjunctiva, which is what we examine for jaundice, and itching worse when undressing. So the child prefers to be uncovered. Next remedy, which you know very well for diarrhea, is horofilum. What is the pathogenesis of this remedy? It causes torpidity of the liver. This word torpidity means sluggishness or slowing down of the function. There is portal engorgement with tendency to hemorrhoids and pain in the hypogastric region and jaundice. So you see a whole clinical picture. The tongue is large and moist. A good remedy for vomiting after milk with portal engorgement. Lot of tenderness and pain in the liver region. The patient is better by rubbing the affected part. There is constipation or it may alternate with diarrhea. In constipation, the stool is clay colored or it may be green and gushing in diarrhea. The skin is moist, warm to touch and has a yellow pigmentation. Last remedy for today is Nux vomica. Nux vomica is last because I don't think I need to explain. It's a remedy you all know and we use it very often for gastric affections. Characteristic tongue where the first half or the anterior part is clean and posteriorly it is covered with a thick furry coating. The edges are cracked. There is nausea worse in the morning and nausea immediately after eating anything. But more than the vomiting, the nausea is associated with a lot of retching. As you know, Nux vomica always has ineffectual urges. So they want to vomit, they want to pass stool, but the urge is ineffectual. When you examine, the epigastric region of the stomach is very sensitive to touch and pressure. There is a lot of flatulent distension of the abdomen leading to soreness. So the abdomen is distended. When you palpate, it will lead to pain in the child. Nux vomica is also a good remedy for umbilical hernia of infants. The clinical word is omphalocele. Some children are born with an umbilical hernia. If it's a small defect, it can correct itself as the abdominal wall grows. It's a good remedy for diarrhea with jaundice. The urine has sediments which may be reddish or a dark and dirty yellow color. And the urine is turbid. Turbid means it is not clear because it contains various sedimental particles. The skin is either pale or it has the typical yellowish color. So this brings us to the end of our session today. It is important to let us just summarize. It's important for us to understand what the meaning of jaundice is, what the various causes are in the neonatal age group, and to firstly differentiate whether it is a physiological or a pathological underlying cause. Once you have diagnosed, you may require certain investigations to confirm the cause of pathological jaundice. Thereafter, assess the degree of hyperbilirubinemia and with more of objective symptoms and observation findings, you can choose the remedy. So I hope you all have understood. If you have any questions, I'll be happy to answer it. Thank you everyone for a patient listening.